Hello, everyone, and welcome to Transgender Healthcare with Dr. Joshua Safer. Thank you so much for joining us today. My name is Jeremiah Jerkowitz, and I serve as the LGBTQ Resource Center Pluralism and Diversity Coordinator in the Office of Student Life here at the College of Staten Island. And welcome to those from across CUNY who are joining us today. This event is being recorded. If you'd like to access the recording, please email me after the event. All students in attendance will receive a CC clue for attending today's event, and Zoom is taking attendance for us, so you don't have to worry about it. I would like to thank the entire School of Health Sciences, Nursing, Social Work, and Physical Therapy for partnering on today's event, as well as the Gender Resource Group, which is our transgender student club on campus. And a special thank you to Professor Catherine Paradiso for the idea for today's event. This event is made possible through the generous support of LaGuardia Community College, CUNY, and the New York City Council through the offices of Daniel Drum, District 25, and Speaker Corey Johnson. So today's event will have a presentation by Dr. Safer, and then it will be followed by a Q&A. So please write down your questions as we go along. So to introduce Dr. Safer, Joshua Safer is the Executive Director of the Mount Sinai Center for Transgender Medicine and Surgery in New York City and Professor of Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Safer was the inaugural president of the United States Professional Association for Transgender Health. Dr. Safer serves as medical curriculum lead for the Global Education Institute of the World Professional Association for Transgender Health and has been a scientific co-chair for WPATH international meetings. Dr. Safer is a co-author of the Endocrine Society Guidelines for the Medical Care of Transgender Patients, the Transgender Hormone Treatment Sections for Up to Date, the current Transgender Medical Care Review in the New England Journal of Medicine, and the current review of Transgender Medical Care in Annals of Internal Medicine. Dr. Safer graduated medical school at the University of Wisconsin, Madison, completed residency in internal medicine at Mount Sinai Beth Israel Medical Center in New York City, and completed fellowship in endocrinology at the Harvard-Longwood program based at Beth Israel Deaconess Medical Center in Boston. We are so excited and honored to have you join us online here at the College of Staten Island. Dr. Safer, take it away.
Well, thank you. Thank you so much for the kind introduction. Thank you for the invitation. Thank you, Dr. Paradiso, for suggesting me. And thank you all for being here, even if here is virtual, but maybe that lets more of us be around. So maybe it's even a good thing. So with all of that, let me just jump right into my talk, which is going to be very much about the medical approaches to transgender healthcare right now in 2022. And then I'm eager to hear questions and thoughts at the end. I think we have a half hour or more budgeted for that. So let me just jump right into the share screen thing here. Super. All righty, so I don't have any conflicts of interest relevant to this talk anyway. And for those who pay attention to this sort of thing, in endocrinology, especially with hormones, we rarely have FDA indications for anything we do. And so that's not even something that's specific to transgender medicine. So my plan for today is to spend a little bit of time going through what happened in establishment medicine, that there has been this sea change in approach to care for trans and gender diverse people. And all along, you'll hear where there are gaps in terms of what we know or what we think we know. And so what needs to be done in terms of shifting strategies or learning what potential best practices could be. And then kind of in the second 2/3 of the talk, I'm going to go through what the medical strategy especially is for care of trans and gender diverse people who are looking for medical interventions. And same thing, I'll kind of talk about what we know and what we don't know. So just want to start out a little bit with terminology, a little differently than other people do, because I think I've seen many of these talks where people open right up and proceed to try to tell me the difference between gender and sex. And I guess those words have different definitions. But right now in 2022, in English, we kind of are using them in an overlapping way as these broad terms. And so from a medical perspective, my view is that we really need to be precise and say what we mean. And so when we're talking about sex, which broadly refers to the biology that relates to reproduction, we can be talking about chromosomes and genes and anatomy and gametes, and also biological things like gender identity and sexual orientation. And we want to be specific when we're referencing those specific items. And so gender identity, even though it uses the word gender, which is more of a construct, and identity, which is something you choose, is really the word we've been using to reference how you know what sex you are, and with a thought that that's pretty much programmed and at a biological level to some degree. And then if I'm continuing along, just other terminology here, the only diagnostic code available right now in the actually all of our medical systems internationally from the WHO is a term called gender dysphoria, which is a mental health term for the discomfort felt by some people when there's a lack of alignment between their gender identity and the sex recorded at birth, which usually means what was observed in terms of the genitals that could be seen right when they were born. And the problem is this is not really a mental health disorder, and so it kind of confuses the issue a little bit. I can talk about that more at the end if people need me to, but the World Health Organization's new international classification of diseases that will come out, who knows, because these are big bureaucracies that take years for things to happen, and who knows even later when it will be adopted in the United States, moves the terminology around, gets rid of this mental health term, replaces it with a sexual health term called gender incongruence, whatever you think of it, makes it at least a medical thing. So another thing just to be aware of that causes trouble sometimes in the organization of our care delivery. All right. In terms of how we're delivering the care, it's good to know what was done historically and is still done to some degree.
I'm so sorry, Dr. Safer, you were muted.
Good. Are we back?
Yes.
Okay. I don't know, a little technical glitch there. So was I muted the whole time?
No, just for a brief,
just for a minute. Seconds. Okay, fine. Okay, all good. All right. So this model here is that what the circumstance has been in a lot of the country and a lot of the world, frankly, which is when we're thinking of this as a mental health condition, that a person who is trans or gender diverse finds a mental health provider who they then need to convince that they are in need of treatment, and that person then casts about for somebody in the United States specifically with prescribing privileges who to get hormones if that's one of the intended interventions, or surgeries with various surgery centers and kind of operating independently in an ad hoc fashion. And kind of what's happened in the field is this change in understanding, which really begins with understanding gender identity. So where we had thought that gender identity was a passive thing, maybe from the environment, maybe it's what your parents told you you were, or it's just a societal construct anyway, or it's a passive response to your anatomy. You looked between your legs and you saw what was there, and you've kind of been living that way. We have this kind of paradigm shift to recognizing that you're knowing what sex you are is a at least heavily a biological thing that's coded. And I just want to walk through a little bit of the data for that. So for those for those who know none of this, to just understand what we're thinking, and for those who know much of this, to understand what is convincing to establishment medical people, especially people who don't provide care for trans and gender diverse people typically, and so for whom this is all very theoretical. And so the first is historical attempts to manipulate gender identity among people who are intersex, or also references people who are DSD. And the situation is just this: somebody born with genitals that are at variance from what we think is quote unquote normal. What it was the case that you would do a surgery, a normalizing surgery, my fingers are up for the air quotes, that was the most straightforward and best established surgery. And because gender identity was passive, you would just simply convince the person that they would have a gender identity to match that surgery. And that for decades, that was the standard approach. And it's actually the case that making female genitalia, that is vaginoplasty, is a better established surgical procedure. And so this just kind of went along until really just about 15 years ago. And so my favorite paper is from 2004 New England Journal, where a surgical group at Johns Hopkins looked at the XY chromosome individuals, so individuals where you would predict that the overwhelming majority of them would have male gender identity, on whom they had done these surgeries. Really, the circumstance was that they all would get vaginoplasty. That was the more established surgery, and then they'd all just be raised in girls as girls. The parents would be in on the story. The kids would not be told their sexual history. They would get hormones at puberty, and they would and therefore everything would be focused on there not being any confusion about what gender identity they ought to have. And what ended up happening with this surgical practice is 4 of the 16 kids on whom they had operated and followed this program said that they were boys. And so they started asking questions, the surgeons and some of their colleagues. And the upshot of it is that by the time they wrote their New England Journal paper, the majority of the kids on whom they had ever operated, of the 16 XY kids, that is to say, were saying that they were boys. In fact, all of the kids who knew their medical history and were still talking to the investigators were saying that they were boys. And it was just simply 5 kids who didn't know their medical history and 1 kid who refused to talk to them otherwise. So pretty dramatic. Nobody has been that careful in looking at their patients, but this has really shifted the medical establishment thinking on the subject. If I'm just kind of going down my list, you can see I divided this into 4 buckets actually, and kind of in order of the strength of the data, in my view, at least. So next down are twin studies, and really I'm just going to reference one paper, which is which is a review of the case reports of trans people with twins. And so in the circumstance where the trans person's twin is a fraternal twin, so not identical, in none of the cases is the twin also trans. But in this case, when the twin is identical, 40% of the time, what's called the 40% concordance rate, the twin is also trans. And to give you perspective, for something like type 1 diabetes, where the biology is well established, for the concordance rate between identical twins is about 50%. Also is important for us to recognize when we're talking to our non-medical associates and friends and such, that identical is just a term. Obviously, identical twins aren't literally identical, and so it's not perfect, but 40% concordance is a really high concordance rate. And the point specifically then is that for people who are the same age, raised by the same parents, live in the same household, have all these very, very overlapping exposures, it's really having the closer genetics makes you more likely to have the gender identity situation also be true. Just moving down the line a little bit, the next basket of data is actually the only one which gets at even explaining influences on our gender identity. The first are just associations to convince us that gender identity is a biological thing, but this third one here, it is really the influence of androgens, so testosterone and similar agents. And on the two extremes, it goes like this: for people who have something called virilizing congenital adrenal hyperplasia, which just is XX chromosome individuals who are, you would typically be consider that female, who are exposed to higher levels for various reasons of testosterone in utero, in their mother's womb. Maybe 5% of those people have male gender identity. And if we think about the percentage of trans people in the population in general, we think maybe it's 0.5% or 1%, depends on your polling, but it certainly isn't 5%. And it just means that for some people who are predisposed, if you bathe them in testosterone while they're developing, that might increase their chance of having male gender identity. And on the other side of things, people who have something called complete androgen insensitivity syndrome, which is where the receptor for androgens completely does not work. So testosterone and similar agents have no action on any of their cells. Those people, if they have XY chromosomes, so typically male chromosomes, their external genitalia are very hormone, well, all of us, external genitalia are very hormone dependent in development. And so they're born with what we would consider to be classic female external genitalia, meaning a vagina. And as they hit puberty, they develop breasts. And the important point, though, for purposes of what I'm explaining here, is that those individuals have female gender identity overwhelmingly. And so the point ends up being that, at least for some people, and maybe for all people, you need to be able to have testosterone action on your brain in order to have male gender identity. If you do not, then you will not have male gender identity. Kind of going down to my last little bucket here is the pretty pictures that people sometimes have looking at areas of the brain that seem to correlate with gender identity instead of with other parts of the body. And the prettiest picture is actually way back from the 1990s, which is a histology slide from slices from brains of course, cadavers. And what they were doing at the time is they were trying to look for biological associations with homosexuality. And so they found this area of the hypothalamus that they call the stria terminalis, and it stains really densely in somebody who is supposedly a straight man before he died. And then here's the brain of a supposedly cisgender woman before she died, not staining intensely at all. And then they went and looked at the brain of somebody who's reported to be a gay man, and he stains just as intensely as the straight man, and so they really have no data, is the bottom line. But they were confused back then, as some people still are, between sexual orientation and gender identity. And so they thought that a transgender woman, so male to female, might be the same thing as a gay man. So they included the brain from a transgender woman, and lo and behold, her staining pattern matches the cisgender woman. That is, it matches gender identity and not the rest of her known body parts. And so they went and did a whole bunch of controls, people who had hormones, people who didn't have hormones, and those sorts of things, and got themselves on Nature paper actually out of the whole thing, and these beautiful pictures like I'm showing you. Attempts to replicate this with MRI and PET scanning have not been nearly as pretty. Maybe those modalities modalities just don't get into the detail like histology, but that's why I have that listed as kind of the weakest of my 4 buckets of data, but still a pretty picture from the 90s. Where this gets me then is if I'm thinking about biological sex, the various components, that is everything in your biology that might be associated with reproduction, then there are there are things we think about, the things we've visualized over the years. That includes some of the body parts that we associate with one sex or another, and the gametes, and sex hormone levels, and but also then knowing what sex you are and knowing what partners are of interest to you. So therefore, gender identity and sexual orientation. And then some of these have influence over each other, like I pointed out with the sex hormone levels specifically, that are responsible for some of the external organ development and may have some influence for some people on, for example, gender identity. So if this is biology, and this is kind of an evolving model of our understanding of the complexity of our biology as humans, what do we need to know about people for whom some of this biology is not aligned, who might be looking for interventions to help align it better? And so this is a list of the various, at the time, changes for the Endocrine Society guidelines for treatment for transgender people. And really, I'm going to point you right to the middle here, where this is in 2017, the 2017 revision, the language shifted to, quote unquote, the diagnosis be made by a knowledgeable clinician, not necessarily by a mental health provider, which is what the language had been prior to this. And so what this then ends up meaning, wait, let me just make sure I didn't skip something. So if we're thinking about what the inputs are in terms of in terms of thinking about the various treatment strategies, among them are the fact that people who are trans tend to come to our attention looking for medical interventions in adulthood or maybe in late adolescence. And we don't have a scan, we don't have a blood test, we don't have any way that we would identify people at a younger age than that. And so we're left with something where people have to come to us by self-report. And why would they come later like this? And you can envision, various reasons. It could be articulation. You have to understand what gender identity even means. Then you have to be able to, you have to have the language to explain it. You have to have some awareness about your own gender identity and your own thoughts. So I had a patient actually just a couple of months ago, a college student, transgender woman, male to female, just comes into me to initiate treatment, and saying to me, all her previous life living in high school as a boy, that she just thought all boys thought they were girls. And, it really hadn't entered her consciousness even to think about something like being trans, and then further, what even to do about it. But bottom line, this is true, and that ends up being relevant from a treatment perspective. And the other thing that's true is that even if we get to that good, happy place in the future where somebody who's trans just comes to their provider and says, I'm trans, can you, help me out? And the person says, sure. The technology of 2022 is that if you're looking for interventions to align your body better with your gender identity, you're heavily looking at hormones and surgeries that are potentially going to interfere with fertility, maybe in a significant way. And there's going to be some tension there in terms of navigating that. So when I'm thinking, as I say, about strategies, one of my favorite pictures to help us think about it, it's a pair of identical twins from about 10 years ago, where they're both XY by chromosomes. So typically male chromosomes, and it's therefore the one on your left who's the one who is trans. And part of the story you can, and all that's happened as when this picture was taken, this is just shy of their 15th birthday, all that's happened is she's received GnRH analogs as puberty blockers. And it's so it slightly points up the idea that female puberty, or what we think of as typically female puberty, is kind of a linear thing. But really where I want to draw your attention is to the brother, to the non-transgender kid, the cisgender kid, and look at the impact of testosterone on what we would consider in what we would consider to be a typical male puberty. So he's just shy of his 15th birthday. And now, again, as you're looking at this picture, think that maybe 2 years ago, the next door neighbor could not tell the two of them apart because they were identical twins. And now look at them. And it's that dramatic change from testosterone over a very short period of time. And we can just kind of look at them a little bit. The little bit of hair over the lip, you kind of might predict, but look at the jaw, the squaring of the jaw, testosterone effect. Look at his larynx down below, where you can envision soft tissue growth in that area, and his voice certainly has dropped at this point. Also look at the SCM muscles on the sides of his neck, and same thing. This is a known kid. He's known, kid at the time he was anyway. He's known to be a bookworm at the time. He was not lifting weights with his head in the gym or anything like that. And so that muscle development is really testosterone effect significant. And so that ends up being important when we're thinking about our treatment strategies. And another way that I think about things is this. People talk a lot about like estrogen versus testosterone, but the reality is that estrogen, at least to the degree that estradiol, which is the estrogen that we measure, is a surrogate, a legit surrogate, that is, for how much for estrogens circulating, really doesn't differ that much between men and women. If you go look at the laboratory ranges, you'll see a lot of overlap there. But testosterone, looking at total testosterone, that's the assay that we use, maybe there is 10-fold more typically testosterone in men than in women. And so what we're doing with trans people from a hormonal manipulation perspective is we're taking testosterone up and we're taking testosterone down. So let's kind of put some of this together here. So the strategy. So first of all, for kids, we want to avoid permanent characteristics if people can come forward early enough. So, I said mostly it's late adolescents and adults who are coming forward and saying they're trans, but there are some younger kids who say they are trans. And so to the degree that we can believe them and perhaps actually already think about things we do before they, for example, before they have permanent things, whether that's the impacts of testosterone that I showed you from that picture, or breast development, let's say in a transgender boy who might be going through a typical female puberty. But even before then, we have something called social transition, which is before puberty. There's no need for any medicine. Hormonally, children are interchangeable, boys and girls. And so if we have a kid who just tells you he or she is trans, then we're really talking about clothing, haircut, who they hang out with, things like that. And this is all reversible. That is, the clothing can be given to the cousin if the child turns out to be wrong. That's kind of the way I would say it. We talk about, people use terms like a detransition and desist and things like that. But I would just call this somebody who thought they were trans, but then they weren't, or they thought they would want to do something about it, but they don't. And that person, like I say, haircut and clothing is easy to switch. And the idea, the fear out there that maybe this kid will get accidentally self-brainwashed also seems pretty unlikely based on our experience with the intersex kids, where when we participated in this global program to convince them to have a gender identity that we wanted them to have, where we actually did surgery on their genitals without telling them and gave them hormones so that they would develop the way we wanted, and had the parents in on the story and didn't tell their medical history till they were age 18, and all of that failed to brainwash these kids. I don't think that simply exploring at school is likely to be a brainwashing event. And I think we can reassure parents in that regard. Still, as these kids get older and they begin to hit puberty, we end up in a circumstance where there are kids who are hitting physical puberty where we're not sure that they have the maturity or of the clarity to either tell us reliably that they're trans or tell us reliably about what it is that they want to do about this. And we have this otherwise. That is, we have kids who hit puberty at way earlier than their peers, when we think they're not socially ready. And we use something we call puberty blockers, these GnRH agonists, in that circumstance to delay things for a year or so until a more appropriate social time. And we have good data for the safety of doing that in people who are adults now, where everything was fine after they stopped those puberty blockers after a year or so, and they're not having anything different that we can identify anyway. And so we can use these same treatments as kind of a conservative intervention for trans kids, where we need a little more time to kind of figure out what it is that we really want to do with them, whether to allow their endogenous puberty to take place or to give them an exogenous puberty to match gender identity. And so that becomes the approach. As the kids actually hit physical changes of adolescence and puberty, which we call 10 or 2, then we can add puberty blockers. And that gives us a year or 2 or so to discuss with family and with the kid and with therapy to think about what it is that that kid wants to do next. Which basically could include giving sex hormones to match gender identity. For adult transgender men, so female to male, pretty simple. Oh, I said already that the big differences between men and women are with regard to testosterone, and so therefore, all we're doing with adult trans men is we're adding testosterone. So that's super trivial, and I'm kind of agnostic for purposes of this talk in terms of how you give testosterone. I'm happy to, if anybody is interested in the details of that, among the 4 ways in which testosterone is available right now in the United States, the 2 common ones are weekly injections and gel that can be spread all over the body, the chest, and things like that. And we can go into why you might choose one or another. But the bottom line of it is it's pretty straightforward, and you can give testosterone and bring levels up to what we would call typical male ranges. It gets a little more complicated for transgender women, because what we're doing in this case, as you can hear, is we're blocking testosterone. We're taking testosterone down, like I said before. And where estrogen fits into all of this is estrogen is the tool to do that. Estrogen feeds back centrally in the pituitary and the hypothalamus and causes all of the endogenous sex steroids to come down. And the caution, though, with doing that is that or the fear, I guess, of having no sex steroids is that you need sex steroids for good bone health. And so estrogen, though, is able to do a double duty here, because it not only helps us lower the testosterone, but it actually then becomes the sex steroid that is circulating for those people and protects their bone. So it's a perfect agent. And we would be done right there and simply give transgender women big doses of estrogens, except that it appears that there is a dose-connected connection for exogenous estrogens and blood clot risk. And so what we end up then doing is looking for ways in which we can decrease the doses of estrogens. We want to give them some because we want to protect their bones, but we don't want to give them infinitely high levels. And that's where we come up with these cocktails where we add some other agent to knock the testosterone down and therefore give a little bit less estrogen. The classic one in the United States is something called spironolactone, which is an old blood pressure agent that's meant to act on the mineralocorticoid receptor, but also blocks the androgen receptor to a degree. We can talk about any of the details of some of those agents later too. So for estrogens, like I say, it's kind of it's the classic endocrine feedback pathway here, where we just take advantage of the fact that estrogens act on the same places in the hypothalamus and the pituitary and cause the entire axis to come down. And then, of course, we're replacing with estrogens. Now, I said that the concern relates to blood clot risk. And so this is the risk table from the Endocrine Society guidelines from 2017. And right up at the top there, we have for feminizing hormone therapy, the fear of thromboembolic disease as being our biggest concern. It's really our best established concern. There are a bunch of other things here listed. And by the way, I'll just point out that pretty much the rest of the list is the subject of potential research, because some of them are just really fears and not known problems. But let me talk a little bit about that thromboembolic risk, because it kind of helps show, as we start to dig a little deeper, something that maybe we know it's true, but isn't as significant as everybody says. And it really does change the care and how we deliver it. So this is a study led by Emory University, using the Kaiser Permanente data out in California, whereby they did this computer analysis and identified about 5,000 trans people. This is 2018, and about 100,000 cisgender controls, supposedly they're controls anyway. And what they found is that there were 3 or 4 extra thromboembolic events per 1,000 persons at about 2 years. And then at 8 years, even worse, maybe 14 to 17 extra events per 1,000 people. And point only is that maybe it's really true that if you give estrogens to trans people, you're going to have some extra blood clots. And so a real thing. But let's look at another little paper here. So this paper, I don't need you really to read any of the details. The main thing is to look at the pattern on the far right-hand side. And what it is, it's a meta-analysis from the British Medical Journal from almost exactly 3 years ago, January 2019, where what they did is they just looking at all the studies for giving estrogens to all people, so mostly cisgender. And what you're looking at, the purple lines, is as they move to the right, it's more blood clots for higher doses of the same product. So for every product they look at, the more you take, the more blood clots you get. And when you add progesterone to that product, whatever the product is, more blood clots get. So that's, some of our patients actually look at progestins as a potential adjunct agent. Part of the reason we stick to spironolactone and we don't add progestins for the most part is, again, this increased blood clot risk. Something else to observe, though, is that when the product is available in a patch form, they observed less blood clots. Now, and that's led to a little bit of a conversation out there, because some people wonder if just by ingesting the pill orally, you have an increased blood clot risk, something called the first pass through the liver effect, where because clotting factors are in the liver, that when that agents go through the liver, that increases your blood clot risk per se, versus anybody who gives patches or gels of any product to people versus having them take it in some other fashion will know that it's pretty inefficient to put it on the skin, and therefore therefore it may just be that the patches, the people who are using patches are getting less estrogen, and it's all just part of that continuum of the higher the dose, the more blood clots, and lower dose, fewer blood clots. So unknown, by the way, which that is. And we could talk about that in more detail if anybody's interested at some juncture as well. So and just another way to look at this, though, because what have I got so far? It's probably true that estrogen increases your risk of blood clots. It's probably true that the more you take, the worse it is. But how bad is it? So this is a study of just shy of 700 people taking oral estradiol for 2 years, and they only observed 1 blood clot in the entire group. So really hard to do statistics there. It doesn't look like the scariest thing. It might be true, but should our patients be panicked? Maybe not. and just other ways to look at this. So Louis Gorin was kind of the granddaddy of the field, running the trans clinic in Amsterdam in the Netherlands at a time when nobody was taking care of trans people much anywhere in the Western world. And therefore he accumulated large numbers of patients who he could follow, thousands of patients. He and his group observed that they had about 6 to 8% incidence of blood clots among the transgender women who they were treating with estrogens. Notably, though, they were using ethinyl estradiol specifically, which is the agent we have in birth control pills. What we here in the United States and some other places have used other estrogen products that are less thrombogenic. And when the Dutch switched in 2004 to start using those other estrogen products, it all of a sudden was the case, even with thousands of transgender people in this clinic, that they no longer observed more blood clots in that group than was being observed in a proportional way across the rest of the Dutch population. It just kind of vanished, the risk. So again, maybe not as serious as we all thought. Maybe there's just a couple of bad estrogens like ethinyl estradiol, which, by the way, we're still using in birth control pills, because even that increased risk is still much lower than the risk of an abortion or a pregnancy. So we all think it's fine in that context. All right, so other data. This is actually from Mount Sinai, came out actually less than a year ago, April 2021. This is there's been this conversation where if estrogens increase your risk of blood clots, maybe you should stop your estrogens when you're about to have a big surgery. And this is highly relevant to trans feminine people where they're on their estrogens, and maybe they surgery that might interest some would be vaginoplasty. And so they come in for this genital reconstruction surgery and they're told, oh, stop your estrogens for a number of weeks because it'll be safer that way. And they get tortured because their hormone levels go down, and that's an uncomfortable circumstance, at least. And so we had some debate among our surgeons. And so we actually did it differently at Sinai at different times. We were able, therefore, just by luck, to be able to look at nearly 500 surgeries that we did when the estrogens were held. This is over about an 18-month period. And we had one thrombotic event in that circumstance. So it looks pretty good. We're pretty aggressive about DVT protocols. We have early ambulation after surgery. We do various injections of heparin and stockings and on all the usual things you would do based on risk. But the flip side is when we just let people take their estrogens right on through the entire perioperative period over a similar 18-month period, I think just the immediate following 18-month period, we had almost 600 patients where we had done some surgeries and we had no thrombotic events. So in the setting of an aggressive DVT prophylaxis protocol, it doesn't seem to make any difference if you stop the estrogen, you're just torturing the patient. So just getting at I don't think that the estrogen blood clot risk is nearly as significant as everybody says. So for trans feminine folks, so we have these adjunct antiandrogens, usually, like I say, to cut the dose still, and spironolactone, I already referenced that one. And then the other agents that are out there are those same GnRH agonists that I've talked about as puberty blockers for the kids. They could be used just to knock the testosterone down, and then you can add estrogens. The reason they're less popular is they're an injection. They're a little more expensive, and the insurance companies push back on us a little bit. But they exist, and they could be attractive. And then cyproterone acetate is the agent that had historically been preferred in the Netherlands and elsewhere in Europe. It's a progestin. I told you that progestins are associated with increased blood clot risk. The Europeans have further observed that there's maybe a little bit of an increase in prolactin in their patients. That seems to be connected to the progestin, and maybe an increased risk of meningiomas. So actually, cyproterone acetate is probably on its way out there too. But just be aware, it's been something that people have used and many people are still taking. So health concerns, are there health concerns? And the short answer so far is, as you've heard me reference, osteoporosis from lack of sex steroids circulating. And so that's like a bugaboo. And people ask me questions like, what about non-binary people? My talk is kind of binary in how I present it. But like anything in healthcare, we pretty much customize. So I have plenty of people who are pretty binary in terms of their gender identity, in terms of their sense of themselves, who want some in-between therapy. And then, of course, people who are non-binary identified, many of them, by the way, want pretty binary regimens for what it's worth, but those who would want a who would want something more in between. And the point is, in between is fine. I don't care if it's more masculine or more feminine. What's not so fine, especially for a young person, is have no sex steroids and have that bone risk. And then the flip side. So it's high doses of steroids. So specifically with regard to androgen, I didn't go into this before, but really the only negative concern with testosterone that's known, and it's not always negative, is that it stimulates erythropoiesis, that's development of red blood cells. It's another reason why it's abused by athletes, because that improves their oxygen carrying capacity with more red blood cells circulating. But there comes a limit, and when you have so much erythropoiesis that your hematocrit goes above 50%, actually the data are for above 55%, that can be a concern with more thrombotic events. And so that is something that we actually follow for people on androgens. And what I guess I would say is, therefore, overdosing on testosterone unnecessarily would be silly, because you're not getting any benefit and you're getting this risk. And then the flip side, which relates to estrogens, like I've been presenting up until now, which is there seems to be this dose connected concern. And so an extra estrogen doesn't do anything more for you physically. And so suffering that risk unnecessarily with very high doses of estrogens might be a concern. So what are we doing as a practical matter? It's actually pretty straightforward. For transmasculine individuals, we just check their testosterone and make sure it's where we want it. We check their, I have CBC here written, but hematocrit or hemoglobin, however you're assessing for that erythropoiesis. The other thing to know is body parts. And I have a slide kind of toward the end of this where I'm going to talk about that just a tiny bit, which is the surgical choices of trans people right now. And, if I'm basically an extension of some of the logic for that I referenced earlier in the talk, where I was talking about how for intersex people, when we thought that gender identity could be manipulated, we preferred feminizing genital reconstruction surgeries because they're better established, and that's kind of still true. And again, I'm happy to go into that in more detail if anybody is interested. But the bottom line for trans guys is that most of them don't do genital reconstruction surgeries and have left their reproductive organs in then often too. And so it just means that if you've got a transgender guy, you do have to think about doing pap smears and such, or to monitor the cervix for potential cancer risk. And then the other thing that I've highlighted here is if you do have somebody where they did spend a lot of time not on any sex hormones for whatever reason, that's going to be a risk for bone, and is something that needs to be followed. For trans feminine individuals, it's the same exact thing. Actually, we're checking the testosterone to see that it's at goal, because it was testosterone up, testosterone down, not the estrogen, not the estradiol level. And then the other thing that we check is if we're using spironolactone as our adjunct anti-androgen, which we heavily are. It's a potassium-sparing diuretic. I won't get into the gory details of that, but the point of it for our purposes is you do need to make sure this person is not sensitive. If they are sensitive with regard to some renal dysfunction, then they are at some risk for hyperkalemia, and you do have to check the potassium when you are first initiating it, and when you are with dose changes. And then the other thing to know with regard to transgender women is, even though the genital reconstruction surgery is well established, works very nicely. It's penile inversion vaginoplasty is what we use typically, which is just what it sounds like, taking the penis and making it inside out and preserving the nerve function and the blood vessels and such, taking the glands and making it into the clitoris, and kind of really rearranging based on the structures that are essentially the overlapping structures that had different influence from hormones in development. But the point relative to what I'm saying right here is that what we do not do is scoop out the prostate. And so those people are going to require some degree of surveillance. Maybe it's less than for cisgender men, I don't know, but some degree of surveillance. They do still have a prostate in there. So one little thing on our lists, we write prolactin. In fact, if you look at the guidelines, they actually say that risk of elevated prolactin is a concern for trans feminine people getting estrogens. And it just is an opportunity for me to point out how little we really know and how important it is to look at the data. So yeah, there it is, right up at the top for trans feminine people. We wrote prolactinoma, which doesn't make sense for a couple of reasons, but the bottom line is elevated prolactin was a fear. Estrogens act on the pituitary and stimulate prolactin. And so it is a logical thing to think from a physiology perspective. But in practice, these are data of mine from when I was still up at Boston University a few years ago, where we looked at all of our trans feminine people at that time in my clinic, and you don't have to be able to read the axes, just these are prolactin levels. It's about 100 people at that time we were looking at, some of them as far out as 6 years. And the main point is you can see the pattern. There's no elevation in prolactin. I had people, because I was an endocrinologist, who had elevated prolactin, who got referred to me to figure out why the prolactin was elevated. And there were certainly made a few diagnoses of prolactinoma, observed some psychiatric medications that are connected to elevated prolactins and things like that. But I did not have one patient where we blamed her feminizing hormone, gender-affirming hormone regimen for an elevation in prolactin like you see. So surgical thing, I said I would comment on that. I think this is my last slide before we jump to questions. For trans guys, my main points, just in terms of our current expectations, are as follows. Chest surgeries, they work well. There should be good access. A plastic surgeon who can do a good masculinizing surgery, that is not somebody who does, let's say, a breast cancer surgery and is trying to make you look feminine afterwards, but somebody trying to make you look masculine, exist. And so these are super popular, and data from when I was in Boston from among my patients getting hormones are just that among people getting hormones, because that's what I can say, over 90% of trans guys are looking for chest surgeries. So they can go to the beach, all the obvious reasons. But the genital surgery, less than 10%. Maybe I'll just even comment on the detail, on a little of that detail, and then I can go into more if people are interested. But it really boils down to this: good plastic surgeons should make a phallus that looks good, that you can feel comfortable taking off your clothes. Let's say when you're at the Y or something like that, or the gym at Student Health, and so that part works. In terms of sexual function, it's not going to, the plastic surgery created penis is not going to get erections like a God created penis. However, we do have prosthesis, and if for somebody who's interested in penetrative sexual intercourse, that can be a thing. And the nerve tissue, the nerve tissue and such is preserved for the clitoris, just not in the new penis, but rather around the edges. So the sensations are in slightly different locations, but transgender men who have this surgery can be orgasmic and typically are. So sexual function could be okay too. The caution really comes with extending the urethra, where our ability to really replicate that which has developed naturally is at a pretty inferior stage right now, and that's where these trans guys are at risk for complications and repeat operations. And so it's basically the peeing standing up. But globally, trans guys are aware that these surgeries are less well established. And so, like I said, under 10% of trans guys having hormones right now are actually looking for these surgeries. What's of interest to me, a little aside, is way back, at the very, very beginning, I said that reproduction is a concern. So for these trans guys, we talk about freezing eggs or maybe freezing embryos. And but if you just really have your ovaries still in your abdomen, which a lot of them still do for the reason I just said, we find that at least in some situations, we've been able to stimulate those ovaries and extract eggs for an in vitro fertilization with donor sperm. we just published a case over the summer at Mount Sinai, actually. A transgender guy had not thought about fertility at all, on hormones for like 10 years, getting to be about age 30, in a relationship with a cisgender woman where, for various reasons, it was determined that it would be better to use his eggs than her eggs. And so they were going to need donor sperm anyway. And he didn't even stop his testosterone, just went through an in vitro fertilization thing, extracted eggs off his ovaries, took the donor sperm, did in vitro fertilization. She carried the baby, the cisgender partner. The kid is 2 years old right now, very healthy. So we publish that as a success. So it can happen. I don't know how likely it is, but I know it's possible. All right, and then the last little point I want to make is for the trans feminine people, for transgender women, with regard to surgeries, and it's this. We're very focused on genitals, and the vaginoplasty really does work, and 50–60% of transgender women really are looking for genital reconstruction surgeries, but if you think about it, genitals are between a person and their intimate others, where especially in somebody who has only started getting medical interventions after puberty and has had a lot of impact of testosterone on her body, really the face is going to be what's important. It's how all the people around you are going to treat you, both from a comfort and a safety perspective. And so facial feminization surgery, which when we're thinking with a cisgender lens, we think, oh, that's cosmetic, where a genital surgery, well, of course, that's necessary because who would do it otherwise? But when we're thinking about transgender people, it could be the case for people that facial feminization is the far more necessary surgery in terms of aligning body with gender identity, even than genital surgery. And really, if you look at if you poll women getting hormones, because that's again my cohort that I got, then they're pretty evenly divided in terms of how much people are looking for facial feminization or genital surgery, and then breast augmentation, I'm saying, is kind of an extension of the facial feminization. All right, so I tried to leave lots of time for us to continue to chat afterwards, and so I think I'm going to stop my share and then look forward to hearing from everyone.
Thank you so much, Dr. Safer. That was fantastic. So now is the time for questions. You can either utilize the chat or use the reactions tab at the bottom to raise your hand. Finn, I see you put it in the chat, but go ahead and ask your question.
Hi, so I'm a trans femme woman, and I'm just curious. What is the medical establishment's standing on dysphoria, and is the medical establishment backing away from there? Because I mean, I get my all of my stuff from Cal-Lord, and they actually do informed consent, where they basically give you all of the different things that are that go along with the health issues. So like, is the medical establishment backing away from the phrasing of gender dysphoria?
Yeah, so you mentioned a couple of things. So yes, for the whole idea of using a mental health term is problematic at two levels, because it first of all makes people need to claim that they're suffering a mental health concern, which they might not. Maybe they are, maybe they're not, but you could be trans and not have any dysphoria, but just simply want your treatment. And to be kind of compelled to stick it, to say it in kind of that mental health fashion doesn't make any sense. And then worse, let's say you really have mental health concerns and want some mental health support. You want to support, you want to separate that out and treat that independently. That doesn't have that. It could be because everybody's torturing you because you're trans. I mean, things are connected, but it could be, but it could be entirely unrelated. And if we're going to be clean and clear in our various approaches, we really do need to divide that. And that will happen. It will just take years. So like I said, WHO already has changed, is going to completely get rid of the term and replace it with this kind of sexual health term instead. And so we will get there. But for the moment, we're kind of in this hybrid bad reality where we're stuck, like for the insurers and for all our computer systems, like still marking gender dysphoria, even though most of us don't really believe it. Or I hope we don't. To the informed consent thing, right? That whole thing is kind of a fight that shouldn't exist even. So, you know, some of the older ways of thinking about it were that you have to convince somebody that you have this mental health concern, and then that got labeled as gatekeeping, and then there was the alternative concept of you just basically show up, and if you sign a document, you can have anything you want. That's the informed consent idea. And we in establishment medicine, we kind of do both, really. And so I think, and so the label for doing both is called shared decision making, whereas we really are gatekeeping. That is, we really do, we are the prescribers of care. We're licensed by the state to try to figure out what's right. And you just can't have anything, witness where we've messed up in some regards, like the opioid epidemic, and you can't just ask for some surgery. So for sure we gatekeep. There's no doubt about it. But on the other hand, we also do informed consent, which is we tell you, well, this is what we understand to be the risks right now of this, and you could choose this, and you could choose that, and you could choose the other thing, and this one's a little safer, and this one works a little better, maybe based on the data what we have. And so we kind of do both, I guess, and that's where I think things should be headed. And none of that, by the way, involves signing a piece of paper and getting some treatment. I don't have anybody sign any pieces of paper particularly. Our surgeons do, because that's kind of standard medical thing for everybody doing a surgery. They sign a piece of paper, but really it's just advising you of how we understand things, and then we make choices together.
Thank you for your question, Finn. Catherine.
Hi, Dr. Safe. That was really an excellent presentation. I have, of course, a million questions, but I'll just leave it to a couple. Cancer screenings, how are they changed in the presence of hormones with prostate, ovarian, breast cancer, when you have, surgical things, hormonal things, the age of the patient, and, are we using more MRI than mammos? Could you speak to that a little bit?
Sure. So, I guess I'm looking at it from a couple of lenses. What we don't want to do, and where we've kind of made a mistake, is we sometimes are overly anxious about the impact of hormones on things, and then we say that people are at risk where they may or may not be at more risk than others. And so so if I kind of go down the line where screenings make any difference at all so far based on data with cisgender people. So for example, mammogram. There's debate among the various societies whether you need to start at 40 and you need to start, or you could start at 50 and things like that. But within that universe, I think we could say that yes, we know that there's some breast cancer risk for cisgender women. It seems to be connected, for transgender women, it seems to be connected for cisgender women with duration of estrogen exposure, earlier menses, things like that, the numbers of children. So it would make some sense that a transgender person who starts hormones a little later in life might be at a little bit less risk. And the data that we have, actually, so far, we are seeing a little less breast cancer in transgender women than in cisgender women. So maybe that's true, but we don't have enough data to have a separate guideline, really. And so we end up, just so that people don't fall through the cracks, saying, oh, kind of do roughly the same thing as cisgender women so that we don't miss a cancer for you, because this happens to be a cancer where we can really prevent it. Variation on theme for cervical surveillance for trans guys who have a cervix, and probably variation on a theme. And again, with all the controversies, should you check a PSA anyway? We can be a little smarter, in some of these. So, for example, with prostate, how much testosterone you have circulating affects your PSA level. So, if I've got a transgender woman who has a very low testosterone level because I'm treating her with a conventional hormone regimen, then I'd expect her PSA to be very low. And if she does have a PSA that's a little higher, that might make me a little bit more nervous. So there are a few little nuances like that. But roughly speaking, what I said initially, other than that, we're mostly just trying to envision what are the body parts and following kind of a cisgender rubric for the moment and not being overly nervous about hormones.
May I just say one more thing?
Certainly.
On the blood clots, I found that data really interesting because I used to work in anticoagulation management as an NP, and we saw, that's what we saw, was blood clots, right? And a lot of times the person was very young. So I just want to say to the students that are on, if you see any of these patients, you should really still be encouraging smoking cessation, weight loss, all the other things that reduce your risk of VTE, because even though it sounds like the incidence maybe isn't as high, there are other things that you might not know about. Patients have genetic predispositions to blood clots, lifestyle, et cetera. So you have to remember that a VTE can be fatal. You know, it can kill you, it can cause strokes, et cetera. So we have to, even though the incidence is, really employ those risk reduction strategies, just as you do with everybody else, with this population as well.
Yeah, and I actually want to jump in on that one a little bit, because as much as I'm saying that we overstate the risk from estrogens, and so we put, these trans women where, at risk for concerns with their care and things like that, which they shouldn't have. The flip side, we make the opposite mistake too, because I see people saying, oh, it's a transgender woman and she had a blood clot and now I stopped her estrogen. And then they forget that the risk from estrogen isn't that high. And so you need to go evaluate some of these other things that you just mentioned and be all over it. And it's not okay. And I see this for trans women getting surgeries at some other places, not big university hospitals for the most part, where they come in and they don't have an aggressive DVD protocol. They're like, oh yeah, we'll make them stop their estrogens for a few weeks. But I don't even know that that's making any difference. And yeah, you want to be all over this. It's silly for a young person to, that's a very preventable, serious harm. And we need to look at all those other things. DVT prophylaxis, put them on anticoagulants if they need it, et cetera. Ambulation, don't smoke, and really push those things.
Thank you, Dr. Safer. Kimberly.
Oh. Hi, thank you for the talk. I'm a current CUNY medicine student. I'm a third year. I'm interested in applying OB. And with OB being such a gendered field as a whole, how do you feel like, or what recommendations would you have, I guess, as a provider or as the system as a whole to be more inclusive?
Yeah, that's you want to create, there are so many places where we have opportunities to make our practices and our environments more inviting. And that one is very fraught. And it's all the obvious stuff. There's so much language we don't need to be having that doesn't have to be as gendered as we have it. Classically, some of our fertility clinics were safe places for trans guys to go because the waiting room was kind of a mixed crowd. Family medicine kind of creates a safe place sometimes because who knows why you're seeing your family medicine doc, and you can get your pap smear while you're there. Nobody needs to know every little detail about your body. And so those are some actual opportunities that we have. But just in terms of how we label things, we have a lot of work to do there, and OB has a lot of work specifically. Yes.
Thank you, Alex.
Hello, thank you. I have a question regarding anti-androgens. Are there any safer alternatives, like if someone cannot use spironolactone? Are there any other safer alternatives for an anti-androgen?
So among the, there are kind of three classic, what I would call adjunct anti-androgens, because even estrogen is an anti-androgen. It's actually the most powerful. So they're the GnRH agonists, the puberty blockers, and spironolactone and progestin, specifically cyproterone, with the one they use in Europe. Among those three, spironolactone is pretty safe. In fact, the data are that it's a blood pressure agent, and as you age, if you develop New York Heart Association class 3 or 4 failure. You actually live longer if you take spironolactone than if you don't. So it's like the ultimate in the safety profile. But if somebody, let's say there's a kidney thing, where your potassium is getting too high, a GnRH agonist actually is clean and nice and pretty safe. And so that might be the logical second choice. I don't know that I'd rush to a progestin, which is what people have done. But I think as we know more and as we mainstream this more, I bet we'll move away from that a little bit. You heard me say a lot about maybe we overstate the risk for blood clots, especially when we're using the pure estradiol products that we use for trans women. It might be the case that for maybe I'd give spironolactone to somebody if I can, but if I can't, I might just, if I can just give them a little more estradiol, maybe that's even a reasonable approach, better than adding a progestin.
Thank you. So we'll do a question from the chat now. Question is, at what age really can you believe a kid wants to change his or her identity?
Right. So they're not changing their identity. It's that they're aware of their identity, just to, to think about it. We talk about development of gender identity, but if it's a biological thing, it's not that it developed, it's that they're developing an awareness of what their gender identity is, and then making decisions about what they want to do about it. And so at what age might somebody have that awareness, and at what age might they be able to make decisions? And it's a huge line. I've sat on panels with grade schoolers who are abundantly articulate and clear, and they're totally hip to the concept of what gender identity means, and they're very oriented to what their own gender identity is. And on the other hand, I've had college students who come in where they're still dancing around the issue, both for themselves and both for what gender identity, and is this I don't know what all the inputs are to somebody's thinking in terms of articulation. Is that actually just different situations of gender identity or different degrees of awareness? But so I think you just are stuck customizing. Obviously, we're on average, we're less trusting of kids. We want to support them, but we don't want to jump too far ahead with them. But like I say, I have college students where it's where we talk for a long time before we do anything medically, because they're still wrapping their heads around what their own circumstance.
Thank you. Sol, you can ask your question.
Thank you. Thank you so much, Dr. Safer. So I've not come across anywhere else this idea of the biological basis for gender identity, and I feel so fascinated and intrigued by this. And I was hoping maybe there was a book or article or anything you could recommend to me to get more information about this.
Yeah, well, I mean, the easiest, because I reference these things in the things I write. So you can look at the data such as they are. I think that's maybe what you would look at. I don't know if there's if you want to have more detail there, that's probably what you would do. You could read one of my review articles, look at the references, and then actually go find those in your library, and they reference yet other references. It's more, it's at that level, as opposed to all being collated in an organized fashion for you. Yeah, and it's just, but that whole I guess that whole model does have huge influence in terms of what we think about what we're going to do with folks, right? That if we're understanding what's hardwired, even if we, or that something is hardwired to a significant degree, then why would you be fighting that? And it's really helped model for people who are not in the field, who are not, when you take care of trans people, sometimes things seem very self-evident, but I have to explain it with some data, with a logic pattern, who's for somebody who's not actually in the field, then that's been a helpful model.
Thank you so much. There was, I'm sorry, one
Go
other thing I wanted to ask, recommendation wise, if there were any surgeons that you would personally recommend for top surgery in the New York area.
So I think that's an offline conversation. Obviously, I think we have the best surgeons at Mount Sinai, but yeah, we can talk otherwise. We have our competitors have some good surgeons as well. I don't think I.
Thank you so much.
Sure.
Thank you, Sol. One of our attendees is curious if there are any trans doctors or scientists doing this research in the field and working on those standards of care.
Sorry, say the question again?
So are there any trans doctors or scientists doing this type of research?
Yes. Like you would, or like I would envision. It's kind of funny because people all worry that there's a that this will be a whole bunch of cis people making decisions for trans people, and I guess there's a history of that. But as we but the numbers of trans people are out there, as we create a more comfortable environment, the numbers of people who come forward then are high enough that what I see happening is people who are trans who go into medical care are just a little more biased to be involved in study of trans care, and so sure enough, we're going to have, if it's a half or a 1% of the population, and I've got a medical school of 150, then or a nursing, I don't know how big the nursing class is, but do the math, and you're going to figure out how many trans people there are. And so we're definitely seeing that. So in our program at Mount Sinai, for sure, I have the trans trainees coming forward and saying, yeah, I want to do this, and people, even if that's not their area of specialty, wanting to make sure that our program is doing the right thing. I have one of our right now we have one trans physician in with a different specialty, but she checks up on us. Our lead surgeon, actually, so not Dr. Ting is our most senior surgeon, but the person who actually trained Dr. Ting is a woman named Marcy Bowers, who's trans and comes out for a few weeks every year. So we absolutely have trans people, like you would predict, make it wanting to come forward and lead, because they have that double perspective of being providers and actually being on the patient side of it too, and making sure that care gets done the right way over time.
Thank you. Another question from the chat. Could you explain the process and timeline for getting a vaginoplasty done, and what is covered by insurance?
So in New York State, most of what we would consider the conventional treatment, so everything, primary care, hormones, and surgeries, are covered by insurance. By rule, it's a necessary, it's obligatory that it be part of the basket of insurance. There are some biases with regard to facial feminization, for example, so there's some work to happen, but in general, these should be covered by insurance. That's true for, I think, about 20 or maybe a little more states in the United States. And that's been true since about 2015, actually. The process for us, at least at Mount Sinai, is you would reach out and and we would hook you up with what we call a readiness facilitation team, where it looks a little bit like some other involved surgeries, if we're looking for genital surgeries anyway, where we need significant patient participation for good outcomes. So similar to bariatric surgery, maybe it'll overlap with transplant, where a social worker just makes sure that goes over with you that you have a good circumstance for recovery based on stable housing and access to your own bathroom and somebody who's going to help you in a postoperative period. We have a mental health person will talk to you, and a medicine person will talk to you. Again, maybe just checking a bunch of boxes if there's nothing going on, or if you do have any sorts of medical issues or mental health issues, making sure that those are all in good shape for greatest likelihood of everything working really smoothly for you. And then one of the priorities for us at Sinai specifically is trying to envision how we take trans care and make it part of what make it look like how we deliver other medical care at kind of the minimum. And so one of the things that's been true for genital surgeries is there's been, people have had to have long waits, years and years waiting for these things. And so we're trying to train enough surgeons and practitioners that starts to look more like, I don't know what something analogous would be, a non-emergency surgery. So a hip replacement, that you can get that in about 3 or 4 months or 5 months. So probably you should be able to have a gender-affirming surgery similarly. We're not there. We're like at like the 10, 12 month period. So after that whole readiness period, next steps are pretty much meeting with the surgeon and getting an OR date with that kind of a time frame. Does that kind of answer the question?
Thank you. I hope so. The next question from the chat: realistically, how accessible are these interventions and affirming treatments to average patients? And I think you talked about this, about the insurance companies. How extensive can the out-of-pocket costs be for patients?
Yeah, so we're so here in New York, pretty good. I mean, again, we're limited by training enough people, and so it's not where it needs to be. But you heard what I said in terms of like the most specialized surgeries, like genital surgeries, chest surgery a little bit easier, facial feminization a little more difficult, hormones easier yet. So we're making great headway, I guess I would say. Other there are probably another 20 states or so where that might be similar, and then there are states that are very resistant to covering care. So we got work to do, and where people have it's not accidental, which baffling to me, have made a political issue out of what is essentially just healthcare, something I just do not understand. And that's creating all sorts of crazy barriers to supporting care and to getting trained people into those states. And I'm totally mystified by that. Honestly, I'll just tell you, like, if you go to medical association or like Endocrine Society, that's my medical specialty home. We have the political parties are well represented. There are plenty of conservative folks, but when we talk science, it's based on the data. So I don't know why what should be just a scientific thing became a political thing, but that it does create a barrier in some other states. And so there's a little bit of a disconnect. As we move outside the Western world, you can envision even more barriers where access concerns. So it gets kind of complicated. Here in New York, I think we're close. We're in a situation where things can be where it's part of the kind of the establishment insurance system for most people.
Thank you. Next question: for trans feminine people going on hormones as adults, how realistic is the development of secondary sex characteristics like breasts, and how important are things like weight gain when setting expectations or family genetics?
Yeah, so for development, there's clearly some connection to age. So when you get your hormone profiles in high school, it depends which direction you're going, of course, too. So if we're talking about like breast development, in high school, pretty good, and in your 20s, still okay. As you age, though, you start to get to an age, maybe in your 50s, where you're at an age where a cisgender person would have had her breasts, would be shrinking to a degree, and so it's going to be more of a hybrid reality. And what was the other second part of that?
Sorry, let me scroll back. Development of secondary breast characteristics, and then how important are things like weight gain when setting expectations or family genetics?
Oh, yeah. So as a rough rule, anybody who has hormones shifting around in their body, and I can say this as being somebody who's done thyroid in the past before I was doing trans, people tend to gain weight. We're very designed to gain weight as humans. And so when things shift, it's the, keeping your weight the same is a challenge. Estrogens are probably associated with a little more of a fat gain. Testosterone is associated with a little more lean body mass and muscle gain, but people do have to be cautioned that when your hormone, you change your hormones a little bit, your bias is to adjust your eating and adjust, and your metabolism shifts maybe a little bit, and you don't, and basically you get a little more disconnected and do tend to gain weight, and maybe want to be mindful of that.
Thank you. I have a question, since you brought up the difference in what states allow for access to care and insurance. Do you find a lot of trans people coming from out of state, or have you heard of workplaces covering transition for their employees?
Yeah, so a couple of things there. One of them is, I don't, so to the first one, it's hard for me to say, because we have maybe about 2/3 of our genital surgery patients right now at Mount Sinai are coming from out of state. But a bunch of that's New Jersey, some of that's Pennsylvania, and then beyond that, it's so much by population. So we do get a lot of people from Florida, and we do get a lot of people from Texas. But is that an access issue? Versus we also get a lot of people from California, where they have some centers out there. So it may be more a population thing than a politics thing. We've been getting people from we've had at least one patient from everywhere, including Idaho and things like that. In terms of employers play a big role, because as much as there's a little bit of politics by the states, for the most part, the insurances was designed for 3/4 of a century, and this country was employer based, with all the problems that we've had with that. But it's also, in this case, it could be a good thing for certain people who are in the right circumstance, where a lot of your large corporations who are looking to attract young people want to be doing the right thing. Care for transgender people is not that expensive. Even the surgeries, your genital, it may seem significant, but if you consider the percentage of people who are trans, and how many times they have one of these surgeries versus like a heart surgery, and a percentage of people who need heart surgery in their lifetimes, this is just not a big concern. The insurance company, if they're just looking at money and could care less about people, this is just not a big concern for them. And so these companies heavily are a force of good in this case. Your Apple and your Google and your big banks, they want to have good trans care because they want all the young people to come work for them, because they want to see how great they are, even if they're not trans. It's kind of a symbol of how of that you're going to be a friendly place. Because if you're a kid, you don't even know what insurance, what healthcare you're going to need. And so this is just an example that they can say, see, we have a great healthcare program, and whatever will come up in your life, we'll take care of you too at the time, kind of thing. And so, yeah, so that actually ends up being a good thing happening out there.
Well, thank you so much, Dr. Safer. We have come to the end of our event. I want to thank you for joining us, and thank you for everybody who attended. I run the LGBTQ Resource Center. We provide a safe space for students on campus, support, connection to resources outside and on the campus. So please reach out if you want to connect. Come visit us in 1C226. Sarah will be putting information in the chat, and feel free to reach out via email if you have questions or need anything. So thank you so much, everybody, for coming, and I wish everybody a great long weekend.
And thank you very much for having me. Really a pleasure. And feel free to reach out with any, for any follow-up on any of these.